standards.
Let's talk about that oversight, Dr. Smith. Were you aware, was IHSC aware, for example, that Dr. Amin, whom you contracted to provide care to detainees for whom you were responsible, had previously been sued by the Department of Justice in the state of Georgia for performing unnecessary and excessive medical procedures?
When we became aware,
When did you become aware?
we became aware through the whistleblower allegation process.
Right, so my question is, were you aware at the time that you engaged his services that he'd been sued by the federal government in the state of Georgia for doing what it appears he did, again, working for you?
No, we were not.
You were not aware. Were you aware from 2017 to 2020, that's the relevant period here, that despite only seeing 6.5% of all OBGYN patients, he was performing 95% of laparoscopies and dilation and curettage surgeries? These are intrusive gynecological surgeries. Were you aware of that?
We became aware after the allegations were filed.
So you were not aware at the time?
No.
So do you vet the doctors you hire?
We don't vet them.
You don't vet them?
Let me finish, if I may, sir. The process includes these providers are not contracted directly with ICE. They are not an employee of ICE. They are referred off-site. Since these allegations, and actually before, we have been sending out different types of letters of agreement with them that they will abide by the different standards of care, that they will provide the informed consent. We now have that as part of our process. But even if these things were to show up in a national practitioner database as a red flag, it doesn't necessarily mean that they're not going to be licensed. If they're licensed in the state and they've been provided credentialing and privileging at different facilities, and we have not received any specific complaints on the physician, we will evaluate it further. And in this particular case, in Dr. Amin's case, he was the only provider in the area that was willing to see these patients. However, we were not aware of all the particulars until the whistleblower allegation.
Did you maintain any process for detecting whether or not providers working for DHS, working for IHSC, were performing an extraordinarily high number of certain procedures, which can be a classic signature, for example, of fraudulent billing?
So the process that we had in place at the time was through the claims process, where we can actually see those claims when they come in, and if there's an overbilling that's occurring, we can catch that. Oftentimes, because of the way the system was currently set up, we wouldn't see those until well after the fact. These providers have up to a year to submit their claims for processing, and at the time, that was the only process we had in place to see if there was these overbilling or debundling of services to overcharge and that sort of thing.
Let's return to the vetting. What I heard you say effectively is that you don't vet, and even if you had vetted, it wouldn't catch this kind of thing. Is that your testimony?
I'm saying that based on the lack of any derogatory information that was in a national practitioner database, specifically as to the type of care, which we weren't performing extensively at that time we were starting to, we didn't have the ability to see that information other than through a claims process.
Well, we found that information quite swiftly. We found that the relevant provider had been sued by the federal government and the state government for excessive and unnecessary billing practices. We found that he'd been dropped by a major insurer for excessive malpractice claims. We found that he was not board certified. Those, I think, would have at least been warning signs to watch a little more carefully, and then during the relevant period, he's performing, again, 90+% of all of these gynecological surgeries nationwide, despite seeing only 6% of OBGYN patients in the country.
Right, and all of these procedures that were referred off-site were vetted through our regional clinical directors for appropriateness. And again, since then, we've expanded our ability.
Yeah, well, I'm sorry, but let me ask about that. They were vetted by all of your regional coordinators for appropriateness.
Correct.
How can that be when we've heard from medical experts who reviewed thousands and thousands of pages of records, and it's the bipartisan finding of the subcommittee that they weren't appropriate? In fact, it's not only that they weren't appropriate, they were dangerous, they were wrong, they were not clinically indicated, they were poorly executed. Women had parts of their cervixes removed. They had underwent transvaginal ultrasounds and pap smears with no clinical indication for it. They underwent laparoscopic surgery when there was no need. They had their uterine lining and endometria removed in part without medical clinical indication. And you're saying that all of that was vetted and approved by your employees?
What I'm suggesting is when these referrals from the clinic came to our regional clinical directors to approve an off-site referral to see an OBGYN physician or a specialist, they approved that. They had no way of knowing exactly what was going to happen subsequent to that referral. Now, since then, we've got some Milliman guidelines that we are in tooling our clinical directors so that when they come in, when they see that here's the procedure that's going to be performed off-site, we've got an evidence-based protocol list that we can actually take a look at. The clinical director looks at that off-site referral as far as the referral being appropriate and says either, yes, we agree that it should be referred off-site to a specialist for further evaluation. What that evaluation may entail, we don't know until after the fact.
We'll return to this in a moment. I'm going to